Well, good afternoon, everybody, and thank you for joining us today for another set of our Handyfoot Transplant Institute lecture series. Today, we're very fortunate to have with us Dr. Mike Aizen, who's a good friend and member of the transplant community and infectious disease community, not to offend anyone here. Dr. Aizen has done his transplant infectious disease training at Mass General under Dr. J. Fishman, and prior to that has done his infectious disease training, I believe it was at University of Virginia. And he's had a stellar career in the world of transplantation, focusing on critical topics along the lines of adenoviral infections, influenza, and more recently in the last several years, he put in extensive effort in understanding disease transmission from donors to recipients, the epidemiology, risk mitigation, and was seminal at the United Network of Organ Sharing in putting together and heading the first committee called, nicknamed the Disease Transmission Advisory Group, DTAG, where they are formulating some of the policies, trying to understand what's going on with disease transmission among donors and recipients. He's the head of the program currently for transplant and immunocompromised host infectious disease at Northwestern University in Chicago, and he's been there for 8 years, doing terrific work. So we're looking forward to his lecture today on donor-derived disease transmission, epidemiology, and risk mitigation. Mike, thank you so much for joining us.
Great. Thank you. Thank you, and it's a great opportunity to come to Detroit, and especially since the wonderful weather cooperated this weekend. So what I thought I would talk about today is a little bit about what the current state of the art is with regard to disease transmission through organ transplantation. And then talk about ways that we can go about preventing that disease transmission. As I'll highlight on these first couple of cases, there are instances where no matter what we do, we will not be able to prevent the transmission of all infectious diseases. And we have to keep that in the back of our mind. But there are numerous instances where either through being more diligent with evaluation of potential donors, either through history, physical, or laboratory testing, we may be actually able to prevent the transmission of infection. And that's the area where I'm most focused on is where can we find those preventable errors to prevent the transmission of avoidable diseases. So I thought I'd run through a couple of cases that really highlight why this is an important topic and why this is of interest to me. So the first case is a patient that I took care of in Boston when I was doing my transplant ID fellowship. He was a 54-year-old white gentleman who had hepatitis B, hepatitis C, and hepatocellular carcinoma, and underwent an uneventful liver transplant and did very well until post-op day number 5, when he developed a fever to 102.4, developed a mild frontal headache when he told us that actually had been going on since the day of the transplant. He had received antithymocyte globulin, tacrolimus, and azathioprine as part of his routine prophylaxis against rejection, and was receiving routine antibiotics for prophylaxis. He worked in suburban Boston where he was an iron worker, and when I examined him initially on the first day, he really had a non-focal exam with the exception of a little bit of a tender right upper extremity peripheral IV catheter. This was removed and unfortunately didn't improve his symptoms. He continued to have fever, and his LFTs over the subsequent couple of days increased relatively significantly. During our multidisciplinary morning rounds, he developed a seizure, which when we went in, the nurse felt was the result of his oxygen falling off and that he may have become slightly hypoxemic. He then, over the subsequent couple of days, had progressive sepsis with progressive rises in liver function testing and a decline in his renal function. And then on about 6 days after this had been going on, we got a call from another transplant infectious disease physician who asked us how our recipient was doing. And it turned out that the reason why she was calling is she was taking care of the 2 kidney recipients from the same donor who had presented with the exact same clinical symptomatology. And when she called earlier in the day over to the lung transplant center, it turned out that the lung transplant recipient had just died of a very similar clinical course. So we reported this to our local health department, and we looked into the donor a little bit. She was a previously healthy lady who died secondary to a hemorrhagic stroke. She donated multiple organs, and in retrospect was found to have purchased a hamster for her son just a few weeks prior to the organ donation. And once the CDC got involved, they borrowed this hamster and did some testing and found that both the hamster and all of the transplant recipients, as well as the donor, were infected with LCMV. And this really raised a lot of questions to us about why didn't we know about this? What could we do to enhance communication between the transplant centers? But what really brought interest to this and got Jay Fishman scratching his head and saying, we really need a system to look at disease transmission is we were all excited thinking we could write this up as the first case, when in fact a very similar case had occurred right here in the Midwest and had never really been recorded or reported out to the other transplant communities. So really this case highlighted an instance where really there was a disease transmission that wasn't well coordinated. We didn't know about the other patients that were getting sick, and that it had happened before. And since we've started collecting the data, there's been at least one confirmed transmission of LCMV every single year in the United States, as well as transmissions around the world of related viruses. And in almost every instance, almost all of the patients either died or had significant late consequences. In the second case, which was one of my first patients at Northwestern, is something that really I think we've probably all dealt with. The patient was a 56-year-old white gentleman who underwent heart transplant right around Thanksgiving 2005. He was receiving immunosuppressive therapy and prophylaxis as per our standard protocols. And then we got a call 9 days post-transplant that the donor had a positive blood culture drawn on the day prior to donation that was positive for Pseudomonas aeruginosa. And there was some significant delays in getting this information to the patient care teams that were taking care of the patient. Partly it was the holidays, so there was some delays in getting this out to us. But then it went to the pre-transplant coordinator who wasn't really sure who to talk to in the post-transplant team. And as a result, 9 days had passed since this information had been known. Fortunately, the recipient really had a low-grade fever immediately post-transplant and was felt to have a UTI based on a positive UA and was put on ciprofloxacin, which very fortunately covered this bacterial isolate, and no consequences occurred to this patient. But if the bacteria was resistant to Cipro, the consequences may have been very different. And really, this case highlighted something that probably everyone that's been involved in transplant has been called about a positive blood culture in the donor, and really should get you to think, what do you do locally to make sure that that information is exchanged very rapidly with the appropriate clinical decision makers, and how do you interface efficiently with your organ procurement organization to collect that information? The third case is the case that really, I think, got disease transmission sort of on the map, in which we had one patient who, very early post-transplant, was identified to have both HIV and hepatitis C infections without any obvious risk factors. And in fact, they had negative testing pre-transplant, and we looked very carefully at this individual, and he really had no risk factors. He was married to his high school sweetheart, had never had sexual relations with anyone other than her, no tattoos, no drug use, no nothing. The only thing that he had done is had an organ transplant. We reported this as required to the Opio, to UNOS, and to the CDC, and a look-back set of testing was performed. We confirmed that the donor was truly negative for HIV and hepatitis C by repeat testing of blood by serology. The donor was appropriately labeled high risk by PHS guidelines. But then subsequent testing of post-transfusion blood on the donor found that he was positive for HIV and hepatitis C by PCR NAT testing. and all other recipients tested positive for HIV and hepatitis C. And sequencing showed that it was essentially the same viral isolate in the donor and all of the recipients. Recently, there has been a transmission of HIV through living donation, and I think this really woke up the transplant community again, because we thought, well, deceased donation, there's all kinds of limitations I'll show you in the next couple of slides, but living donation, we really should be doing everything possible to screen the donor to prevent the transmission of infection. But what happened with this individual is that the donor was a male prostitute who donated to his sister in a distant city. He went up about 79 days prior to the organ transplant procedure, was tested, and had all of his testing come back as negative. He returned to Miami, where he resumed his work as a male prostitute, and then returned without any additional HIV, hepatitis C, or other STD testing, even though he had a prior history of syphilis as well. And it was well known to the transplant team and to the recipient that the person was a homosexual male who was also a male prostitute. He didn't undergo any additional testing. The transplant procedure proceeded without any difficulty, but then the recipient developed oropharyngeal and vaginal candidiasis that was relatively refractory to care. The donor then, at about a year post-transplant, went in for his annual HIV screening and was found that he was HIV positive. He reported this to his sister, who was the recipient, who told the transplant team who tested her, and it was discovered that she too had contracted HIV. And likewise, they had done some sequencing to show that it was basically the same virus that was transmitted from the donor to the recipient, and residual blood that was tested 11 days prior to donation as part of his HLA workup was found to be PCR positive for HIV. So this really highlighted, in my mind, two things: that we need to be very diligent about what testing we do, particularly in our living donors, but also we need to be very cognizant about how close to the transplant procedure we're doing the testing, because clearly this was truly a preventable transmission. The last case that I'll present to you really is to focus on the fact that although we think of organ donation as its own field, we intersect with a lot of other areas in medicine. And in tissue donation, it is required that donors have NAT testing or PCR testing to screen them for HIV, Hep B, and Hep C. And that is not currently required for organ donors. What happened in this instance is that the donor was both an organ and a tissue donor. He tested negative by serology, and organs were implanted, kidneys and livers and pancreas, into organ recipients. The tissue was quarantined, tested, and unfortunately, a positive PCR test was mislabeled as negative. This led to the release of the tissue, and it got used and resulted in the transmission of hepatitis C to at least one pediatric heart tissue recipient. Unfortunately, the disconnect between the fields was demonstrated in this case as well, because the recipients of the organs presented with acute hepatitis and were eventually diagnosed with hepatitis C, but this wasn't efficiently this information wasn't efficiently reported to the tissue banks. So really talking about some of the issues about making sure that we have good linkages when we have donors that are donating both organs and tissues. So these, I think, have been useful cases to think through some common challenges to disease transmission through organ transplantation. But I think before moving on to what the epidemiology is, we have to really think about why is it that these could even occur. Well, I think we all recognize that there's a restricted timeline between the time when a potential donor is identified as a donor and when organs are procured. This limited time frame limits the amount of tests that we can do, prevents us from doing all of the confirmatory tests that we would optimally like to do, particularly if you have a positive test. You may not have time to discriminate, is that a true positive or a false positive result. This also leads us to have a different screening paradigm than, for example, blood donation. Whereas blood, the goal is to get the risk as close to zero as possible. organ transplantation, we recognize that there will be some transmissions of infections and malignancies, because despite all of our efforts, you're taking fresh tissue out of a living human being and placing it into another individual. And there's just no way to prevent all transmissions through that process. Third, the donor history is truly a secondhand story from deceased donors. There's no way you can get all the details of what that donor has been up to by talking to friends, family, loved ones that are distraught at the loss of their loved one. And I really kind of hark to two very exemplary cases. A lot of our donors, unfortunately, are young individuals, perhaps in their 20s. And if you think back about what you were doing when you were 24, how much of that did your parents or friends really know that you were doing? And so if they were asked to disclose information, would they be able to give a truly factual history? And even if you look at what you do on a day-to-day basis, typically your spouse even doesn't know what you've been up to all day until you get home over dinner. And so if, God forbid, you got in an accident and that's when you became a donor, that spouse wouldn't know that you ran into a rat that bit you when you went in to get coffee that morning, even though you planned to tell her about that over dinner. The fourth challenge is that we have some real challenges with our data collection. And this is where our move to contemporary technology, I think, is actually hurting us. As more and more hospitals have moved to electronic medical records, this has actually made it harder for OPOs to actually collect all the information on our potential donors. And I look back to when I first moved to Northwestern. The way our electronic medical system is set up is the results sheet only shows 1,000 results, which seems like a lot, but every little test, every sodium counts towards that. And all of our microbiology tests and serologies are at the very bottom. So it wouldn't be surprising that if the positive blood culture was result 1001, it wouldn't show up on that sheet. And I actually, as an infectious disease attending, got burned once because there was a positive result one day that wasn't there the next day, and I thought it had been retracted. I didn't know that I had to push this more button to pull up more results. Now, if I don't know about the more button, how is an OPO person who comes into the hospital maybe once or twice a month going to know about all the nooks and crannies in our healthcare system? And I'm sure you have problems here with your healthcare system where, oh, you don't look for this serology in serology, you look for it in this area. And it's a real challenge. The next issue is, as we'll talk about later in the presentation, is our screening is reliant on serology and was exemplified by the transmission of HIV and Hep C. This is going to miss positive infections in patients that have had a lot of blood products resulting in hemodilution or who have recently become infected during the window period after infection. We have variable NAT capacity, and as I'll show you some data that we presented at ATC, fortunately, this is improving over time, but there are still some areas of the country that don't have the ability to do NAT on every donor at every hour of the day. But most importantly, we have to keep in mind what we're pushing against. Our field has been so successful that the number of individuals being listed for transplantation has really grown almost exponentially. So that there's now over 120,000 individuals waiting for transplantation that have been successfully worked up and are ready for an organ. Unfortunately, we only have about 25,000 organs per year to give to those individuals. And that results in close to 10,000 individuals dying every year while waiting on the transplant list. And so we have to be very, very careful with how we balance things. We want to make sure that we do the best job that we can to prevent disease transmission. We want to make sure that patient safety is a priority. But we have to make sure that we don't throw out excess safe organs that could be used because we're too worried about disease transmission. So we have to balance organ availability with patient safety. So what have we been doing to really understand what the epidemiology is so that hopefully we can start to fill in the gaps, reduce the risk, and improve both the safety and the efficiency of our transplantation? Well, currently there are two policies that are on the OPTN books related to disease transmission. The first is policy 2.2, which requires OPOs to obtain a medical and social history on every donor, to review thoroughly the patient's donor chart, to perform a physical examination on the donor, and to obtain FDA licensed, approved, or cleared tests for HIV, Hep C, Hep B, CMV, EBV, and syphilis, as well as additional cultures. And then policy 4.1 that deals with not using organs from HIV-infected individuals, and policy 4.4, which requires us that as soon as we consider that there is the possibility of a disease transmission of donor origin, that we report that to DTAC and to the OPTN. And this is important. I want to highlight that. It's not when you know that you have the transmission. It's as soon as you think, maybe this could be a disease transmission. That's when you need to do the reporting. Because you don't want to get into the situation that we got into with that first case, where you're fishing when someone's already died, when maybe your fishing could have prevented that death or resulted in earlier interventions. So once a case is reported, what happens? Well, the cases are entered through the patient safety system and sent to one of the patient safety staff members. They prepare a summary of the event that as reported to them and remove all patient OPO and transplant center identifiers. And I'll tell you, they're so good that when it was a report coming from our center, I'd have to ask Shandy, is this our case? So they really do a very good job so that this is absolutely blinded. We have no idea where this case is coming from. The materials are then uploaded to a password-protected SharePoint server, and an email is sent out to all the members of DTAC, and I'll show you who they are in a second. This results in an email-based discussion group where we go back and forth and talk through the different cases, what's going on, what more information do we need to determine whether or not this is of donor origin. We then require that the transplant centers and OPOs provide us with a 45-day summary report in which they tell us all the evaluation workup that they have come up, and we actually ask them, do you think this is a disease transmission or not? Although we make the final assessment, oftentimes the people on the ground are very helpful in making this determination. There's a monthly conference call where each member of the committee is on the call, where we talk through all the cases that have been submitted, and we've gotten through day 45 to really make some assessments. And then twice a year, we look at all of the data to try to determine, is there education that needs to be done? Do we need to suggest policy changes to improve safety? And rarely we will have special cases. If it's a reportable disease, the Centers for Disease Control actually gets informed and now leads the investigations. And if we feel that there isn't sufficient communication going on between the transplant centers, there may even be an event-specific conference call. We then have a risk scoring system in which we then classify cases as either proven when we can determine that the malignancy or pathogen was present in both the donor and the recipient, down to excluded where disease can clearly be stated to be from a source outside the donor. One group that we actually have been increasingly classifying groups in is this intervention without documented transmission. And this is, let's say you have a donor that has a positive syphilis screening, all the recipients get treated with penicillin and nothing happens. Well, we can't make an assessment. We don't know whether there was a disease to be transmitted, whether it was effectively treated. So we've created this category to capture this sense of uncertainty. The committee has grown substantially over the years, and our goal with this is to do a couple of things. One, we want to be broadly representative, and by this we mean that we want to make sure that there's people from all around the country, from every nook and cranny and part of the transplant system. We've got people from the OPOs, lab directors, medical directors, administrative directors. We've got people from the OPOs, from the transplant centers, the surgeons, the physicians, the coordinators. We've tried to involve everyone, because the one thing that we learned through this process very early on is as soon as we thought we understood what was happening, the expert that really was responsible for us would tell us, maybe it doesn't work exactly the way we thought. What have we found through this reporting mechanism? Well, last year was our kind of bumper crop year. We had 181 reports made to the system. We're on track currently to go above 200 reports this year for the first time. Now, the challenge, though, is that not all donor service areas or OPOs are reporting to the same degree. And whether you look at that as absolute reports, happy to say finally we have at least a single report from every OPO, but you can see there are some OPOs that are reporting a lot of cases and some OPOs that are reporting practically none. And this doesn't correlate with metrics such as the number of increased risk donors, the number of donors that have certain positive markers for infectious disease. There's a lot of variability. We've also looked at this in terms of number of reports per procured organ. I'm happy to report that Region 10, where we are today, is actually right where we'd love them to be, kind of in the median of reports. So you're doing a great job of recognizing and reporting these cases. But there are some areas, Region 1 for example, that have very, very low rates of reporting relative to a very high number of transplants that are being performed. So what have we found through this system? Well, there's been 704 reports with 205 that have confirmed recipients affected with either malignancies or infection, and 67 individuals that have died due to confirmed donor-derived disease transmission. This seems like very high numbers, but it's important to recognize it's actually a relatively rare event. We estimate based on these numbers that it's about 0.2% of all recipients will have a donor-derived disease transmission confirmed in them, and far less than half of those individuals will have mortality or loss of organ as the direct result of that disease transmission. I'm not going to go through it in a lot of detail. This gives you a little bit more granularity on what we see with regard to malignancies. Although I'm going to be focusing on infections, I thought I'd put this in here. Really, we see a lot of reports, for example, of renal cell carcinoma, although that's very infrequently transmitted to the recipient and very, very, very infrequently results in the death of the patients. Other malignancies such as leukemias, lymphomas, melanomas are more frequently associated with disease transmission, and when they do get transmitted are associated with far more mortality. We've had a number of infections that have been confirmed as transmitted, and it's very interesting looking at the breakdown of these. In general, a lot of the reports that we get with regard to viruses are what I would term false positive or non-reproducibly positive markers. So a donor is a donor for organs and tissues. They have negative testing for the organs. They go and get sent to the tissue bank. The tissue bank comes up with a positive PCR for HIV. It gets everyone worked up. And lo and behold, we go back, do additional testing, and follow up on the recipient, and there was no HIV that was there. Nonetheless, there have been some viruses that have been transmitted, some with fatality, including things like LCMV, rabies, parvovirus B19, and rarely some of the hepatitis viruses and HIV. Bacteria have been the number 2 donor-derived disease that has been recognized. Frequently, when this is transmitted, it's due to highly resistant bacteria, MRSA, VRE, MDR gram-negatives. And when there is a case that's recognized, frequently there is some sequelae in the patient, whether that's rupture of an anastomosis and loss of an organ up to the death of a transplant recipient. I think of all of the types of infections, bacterial transmissions are the one that we probably do the worst job of recognizing and reporting, because I know a lot of times you'll see a patient who gets post-op day 3 MRSA bacteremia. Most people just assume it's because of the line they got placed in the hospital or they've been in the ICU for weeks, when in fact we should be looking back at the donor cultures, making sure that it's that the donor isn't positive for that same pathogen. And if it is, again, report that so that appropriate therapy perhaps could be initiated in other recipients, while evaluations such as sequencing of the 2 bacteria can be done to see if it's the same resistant bacteria.
Are you able to tell us the exact number of hepatitis C and HIV transmissions?
Sure. So with regard to HIV in the United States, there have been 2 HIV transmissions that have been confirmed. The living donor transmission and the transmission in Chicago. For hepatitis C, I will have to look back, but there's been, I believe, 5 transmissions, but I'll have to look back and check my numbers after
You
that.
don't know it was part of this 2005 to 2011 cohort.
No, these are all from that cohort, yeah. Fungal infections, we've recognized an increased incidence in really 2 types. The first is endemic mycoses, cocci, histo, blasto, and it really highlights some of the challenges. So you have individuals that are flying and traveling all over the world and all over the country. And so the best example of the histo transmission was reported in one of the infectious disease journals, where a patient who lived in Indiana all of his life moved and got in a boating accident on the West Coast. No one even thought to do testing for histoplasmosis, even though he had some changes on his chest x-ray that were suggestive of acute histoplasmosis, because he was not in the region of endemicity, and the disease was transmitted to all of the recipients. The other thing that we've been seeing, and we are wondering if this has to do with the larger doses of steroids that are being used for the donor stabilization, is we've been seeing a higher incidence of cryptococcal transmission through organ transplantation. And we know that steroids can facilitate even low levels of these yeast getting into the bloodstream and potentially being transmitted. There have been 10 cases of TB that have been transmitted from donor to recipient, and it's really important to recognize that most of these TB transmissions don't result in a pulmonary primary manifestation in the recipients. Frequently, it's downright sepsis. People just have fever, sepsis, because they have a disseminated infection and don't present until somewhat later with tuberculosis. And interestingly, recently there have been several transmissions of parasitic infections, particularly, again, strongyloides, which we suspect may be related to some of the higher doses of steroids that are being used, which is allowing a parasite that traditionally is limited to the GI tract to becoming secondarily disseminated in the setting of steroids, and thereby being transmitted through transplantation. We've also recognized some processes that could be improved to minimize the risk of transmission. We've recognized that communication is a real challenge sometimes. There currently is a very inefficient system in place in the United States. So if you had all of the donors even today, or sorry, all of the recipients today that had a very similar presentation where sepsis was the presentation, much like that very first case I showed you, unless they were being managed by the same team, the same transplant ID team at the same hospital, it probably would still get missed very early on today. So we really need to be doing things to facilitate communication. And actually, 2 years ago, the OP10 passed a policy 4.5, requiring all OPOs and transplant centers to have a patient safety contact. And really the goal of this is to have a point person at the OPOs and the transplant centers that can facilitate transfer of information from one center to the next. But it's also important that we all take responsibility. If your center gets called with a question of how your patient is doing, it's imperative that you don't just tell them, patient's fine, as of a week ago, that you actually call the patient and see if they're doing okay, and if they're not, have them come in to be evaluated. We don't have a good system currently for recognizing donor-derived disease transmission. Although we have a great way of collecting data on donors, we don't actually have a good way to do cluster analysis. One of the things that we started 2 years ago with DTAG is looking at cluster analyses for malignancy. And with that, we found at least 2 malignancies that were concerning for potential donor-derived malignancy transmission that were only identified when we really started looking to recipients being reported as having the same malignancy that would be a little unusual for them to develop very early post-transplant. We are really good at recognizing when something bad is happening to our patients. So when someone's dying in front of our eyes, when there's something really weird, but we're not very good at identifying when there's Staph aureus in the blood culture and determining whether or not that's of donor origin. We don't have as good of a system, and just talking with a lot of centers, and our center up until about a year ago was much the same. We didn't have a good system in place for when the OPO calls to the coordinator, who do they talk to in the transplant center to actually pass that information on to so that something gets done? And that what if that person that is responsible is out sick or is on vacation? Who does that get rooted to? There's a lot of issues, as we're going to talk about in a few minutes, about the whole issue of increased risk donors, or what a lot of people refer to as high risk or CDC high risk donors. How do you classify them? What does the risk mean? How do we evaluate those patients? There's an increasing recognition to human error. And I think that the last case I presented to you where the PCR was positive, but it was labeled as negative, that was because someone physically did the wrong thing. And we really need to do put in place systems that protect the safety by getting rid of human error. And I think we've recognized that live donors, although the risk is much lower, they're not immune to disease transmission. So how do we go about preventing disease transmission, or at least mitigating against the risk? Well, we can do things such as be very careful taking medical and social history. And there's a process that's well underway in which there's that's being led by the American Association of Tissue Banks to develop a national uniform donor health questionnaire so that at least there's some consistency with how questions are being asked. And there's been some science put behind this to develop questions that when you say, have you had sexual relations, people know what you mean by that. When people say, have you traveled outside the United States, they know that that means anywhere outside the United States, including Mexico. So, because a lot of times people will say, oh, I've never traveled outside the United States. Oh, but I've been to Mexico, I've been to Canada, I've been to the Caribbean. Oh, or I've been in the military. That may have taken them someplace. Again, these are ways to get better quality histories from individuals. We can do things to improve screening of blood, and I'll show you that in a few minutes. And then the last few minutes of the talk for the remainder of the time, we'll talk about how we define increased risk donors, what's been proposed as the new definition, and then lastly, the one area where I think we all need to be doing a better job, and that's screening our recipients, particularly those that we offer increased risk donor organs to. So currently our standard of care for screening is ELISA, or detecting of antibodies. And basically it's a very simple system where you'd get the results that you see in the bottom panel. And if I gave every single person some ELISA plates and positive and negatives, you would all be able to do the test without any problems. You'd get the right answer. You wouldn't be splashing around specimens and getting false positives. So it's very, very safe and reliable. The challenge, though, is that once you become infected, there's a period of time when you develop viremia, but before you develop antibodies. And this is termed the window period. And that window period can be anywhere from 22 days for HIV up to about 66 days for hepatitis C. We can do things such as directly detecting the presence of that virus by using NAT, nucleic acid testing, PCR, whatever term you want to use, and help reduce that window period. It's important to recognize that that window period doesn't disappear. It doesn't go to zero. So if you have a donor that died with a needle in their arm, the testing that you're doing is only determining what was happening in that patient 7 to 9 days ago, or 22 days ago in the case of hepatitis B. So what we tried to do, and we presented this at ATC, because one of the concerns about using this PCR or NAT testing was that it wasn't broadly used or broadly available. So we conducted a survey of all 58 OPOs in collaboration with AOPO to determine what the current state of the art is for testing. We got 100% of the OPOs responding. Some basically said that they didn't want to be contacted. When we reported this at ATC, 2 OPOs basically left the survey blank. Since then, we've gotten those 2 OPOs to respond to us and give us results. What we found is that when NAT testing was being done, the majority of OPOs are sending the test off-site. Only 6 of the OPOs are actually doing the PCR in their own lab. So that's clearly the minority. But we found that there's been a significant increase over time in the number of OPOs that have the capacity of doing PCR NAT testing for HIV. Only one OPO is not doing that currently, and hepatitis C, where 2 OPOs are not currently doing it. Clearly, Hep B, although it's improved, is still lagging behind. I'm less worried about that because I think we have good tests with the surface antigen test that allow us to directly detect the presence of the virus. Then we asked why you do the testing. Well, clearly, we thought we would see that most OPOs would tell us just because of increased risk donors, whereas the majority of OPOs that responded, over 50%, are currently doing NAT testing for all deceased organ donors, at least for HIV and Hep C. How often is that information available before the transplant decision is made? Almost all OPOs have the information back prior to the decision being made, and when it's not the majority of the time, it is available. Only a very small proportion, less than about 10% of OPOs, don't have that information at the time that the decision is being made. The thing that was most concerning to us, though, is if you get a positive test, we asked, what do you do? And unfortunately, most of the OPOs do nothing. They report it, and that's it. Well, the problem with that is then if you have false positives, if you have a problem in your lab, you're never going to know that. And really what we're hoping to do, and part of the reason why we're writing this up now, is we want to convert most OPOs from no to most OPOs saying always. Because really, especially now as we're just learning how to use this testing, we really need to be doing confirmation so that we can understand what instances are we making errors, in what instances is it challenging to do the NAT test. But unless we do that confirmation testing, it's impossible for us to know that. So then we started to ask the question, well, should we use NAT testing or not? Clearly, at this time, this is probably one of the biggest debates within the transplant arena. And this was driven in part from a consensus conference that was held 3 years ago. And the group concluded that NAT testing should only be used in increased risk donors because of the concern that you may actually lose a significant number of donor organs from false positive testing, and that there was concern that there was insufficient capacity within the OPO community. I think we've ruled out the insufficient capacity with our survey. Now the question is, should we really only be limiting it to increased risk donors? So we collected data from 3 OPOs, 3 OPO labs that represent about 35% of all of the organ population. And we got dinged when we submitted this to a journal. They said, well, why didn't you collect it on everyone? Well, I'll tell you, this took almost a year of a fellow's time collecting this information. I'm amazed she has any hair after doing this. It was so painful. So we are in the process of trying to collect all national data for 2010 so that we can get national information. But it's really hard because we don't actually have it collected. Additionally, our goal was to prove how many of these were false positive, but since most of the labs aren't doing confirmation testing, we actually weren't able to very carefully do that. So of these labs, they represent about 15 OPOs, a third of the US donor pool. They do standard assays per the package insert for serology. 2 of the labs do PCR-based testing, which doesn't have a built-in confirmation step. And one of the labs uses a TMA assay system where basically you do a multiplex assay. If it's positive, you have to do confirmatory testing, and it's part of the package insert what to do if you get a positive result, if you get a negative result, how you report that out. The one lab that used PCR did not do any confirmatory testing. The second lab only did confirmatory testing when requested by the client, the transplant center or the OPO. And the third lab did that confirmatory testing as part of the FDA-approved assay system. So how many tests did they do? There were about 3,977 individuals that were screened. By serology, about 10 individuals, 0.3%, were HIV positive by serology. About 8.5% were positive by one of the two hepatitis B screens, 0.9% with active infection by serology, and 6.3% of individuals were hepatitis C positive by antibody. Of these, there were about 3,624 patients that were tested by PCR-based testing for HIV and for hepatitis C. Only about 501 individuals, because only one of the labs did PCR testing for hepatitis B. And what did we find? Well, where everyone has focused their results is this upper corner here. How many false positives did we get? Well, there were 10 individuals that were seronegative NAT positive, 2 of whom we were able to confirm by subsequent testing were truly false positive. They did additional testing, it was negative. The other 8 individuals did not have confirmatory testing, and it is unclear whether they represent true positive or false positive, but none of the organs got used in those individuals. 0 patients were Hep B NAT positive and seronegative, and 5 individuals, or 0.1%, were hepatitis C NAT positive, seronegative, and there were no confirmatory testing on any of those individuals. But where I like to point out where people have ignored completely is what's going on here. Seropositive NAT negative, 1 for HIV, 60 for hepatitis B, 64 for hepatitis C. Now we know that in the case of hepatitis C, about 15% of individuals will successfully clear the infection themselves. So they'll be antibody positive, PCR negative. And there is not a residual form of the hepatitis C in the liver, and these individuals likely represent very safe organs to accept for our transplant population. Now, clearly, before we start accepting these willy-nilly, we would want to do some studies, make sure that a disease wasn't transmitted. But if all of these individuals represent additional individuals that either are false positive serology that can safely be used, and definitely these NAT negative Hep B serology positives could be used in selected individuals that were vaccinated that had Hep B disease, we could actually add 124 additional donors to the pool that are either not being used currently or being very inefficiently used at this point. So even if all 10 of these individuals are false positives, these would be well outweighed by benefit by using PCR testing. So in my mind, this provides preliminary information that NAT testing may be of benefit to the transplant field. So then we move to the issue of increased risk donors, where there has been a lot of focus. So, most of us are familiar with what the current guidelines say, that basically people that have risk factors generally within the past 5 years. And there's been a call by the transplant community to really revise these guidelines, to bring them more up to date, to use contemporary knowledge. Part of the issue, though, we need to realize is we're still using these definitions. And because of that, we have to be able to quote the patients when we're offering them these organs, the actual risk that we're presenting. And really, until we started pulling this data together so that we could start talking to patients with about the risk, I was actually suspicious that if you had an IV drug abuser, the highest risk for HIV and Hep C, that had PCR testing, that the risk would be still a little bit higher than many patients may be willing to accept. But if you look at the actual data, the rate of undetected hepatitis C in a NAT screened organ donor that was an IV drug abuser is about 3.7%. And the question then came, well, what's the risk of hepatitis C being contracted on hemodialysis in 1 year? Well, according to the USRDS, it's 3.4%. So really, if you have a kidney recipient who's going to dialysis tomorrow, there's very little reason for them, because they're willing to take the risk of going to the transplant or going to the dialysis unit, to not accept even the highest risk donor for kidney transplantation. And I think if we do a better job of putting the risk in context, I think many patients that may be unwilling to take increased risk donors may be willing to take that risk. And then if you start looking at some of the groups, even things that people may have a thought represents a very high risk, that if we use NAT testing, the risk drops down substantially, so that the risk of them contracting an infection is less than 3 per 10,000 donors for HIV, for example, in a NAT screened homosexual male.
You meant, say, 0.37%, right? Not 3.7%.
Oh, sorry, 3.4 per 10,000.
Right, so that's 3.4%.
Sorry, 3.37, yeah.
And 3.7% annual is for CDC High Risk kidney for the dialysis patients.
Well, it's for just being on dialysis.
3.5 for being on dialysis to contract hepatitis C.
Yeah, sorry, 0.34. I did misquote, sorry. 0.34 versus 0.37. So it's essentially the same risk. So now we've asked, what's going on? We've asked for the next slide. It's not going. But I'm down to the last couple slides, so I can talk without looking at the slides. We've asked for this guideline to be amended, and the PHS has done exactly what we said. We may disagree on all of the details, but what they've generally done is they've narrowed the time frame from 5 years to 1 year. They have been far more clear when they say donors that are incarcerated. They've been very clear. What does that mean? That doesn't mean that they just were in jail for a couple of hours, that they actually spent the night for at least 3 days, 3 or more days in jail. They have provided us a lot of details about the donor screening that we should be doing. And again, some of this is debatable about how accurate it is and how happy we are. But overall, I think that this represents a much more tightening of the increased risk population, such that it probably represents, and we're actually working with our OPO to look at this number, about 20% of the current population of individuals that are labeled as increased risk will be labeled as increased risk based on the proposed guidance. So really it represents a much smaller, much more tight group of individuals that are screening positive based on the testing. Since this is moving forward, the last thing I was going to talk about is what to do about individuals that you give transplants to from an increased risk donor. So it's my perspective that if you're telling a patient we're offering you an organ that may be infected, you have an obligation to test that individual for to confirm that you did not transmit that infection. Yet, unfortunately, looking at the OPTN data, where there's only data for about a 1-year period, 6% of individuals that are offered an increased risk donor have post-transplant testing. We then did a survey of all of the transplant infectious disease experts. The reason why we picked that is we figure if you have an engaged group of experts that are being listened to, hopefully by their transplant center, that are engaged, you have a higher likelihood of being at a center that is going to do something about screening those recipients. And only 54% of those transplant infectious disease physicians said that they currently are at a transplant center where there is a standing protocol to test recipients post-transplant for HIV, Hep B, and Hep C when they are given an increased risk organ. And again, my feeling is that we really should be doing a good job. What is debatable is when to do that screening. What came up from the consensus guideline was to do it at 1, 3, and 12 months. It's probably a little too much. But what isn't clear is that we shouldn't be doing serology. Serology will miss every single one of the hepatitis C transmissions that we've confirmed. Patients, when they contract hepatitis C through organ transplantation, at least in the cases that have been identified in the United States, do not seroconvert until you discontinue the use of immunosuppressive medications. And so you do need to do PCR-based testing. So with that, hopefully I've covered a lot of groundwork, talked about the epidemiology of donor-derived disease transmission, talked about ways that we can mitigate against the risk of disease transmission through more accurately collecting history, more accurately doing better testing for screening for donors, and looking at recipients, particularly those that we've offered that have risk factors for disease transmission, so that we can mitigate against the risk of disease transmission. Thank you very much, and I'd be happy to answer any questions that you may have. And I'm sorry whoever's computer I killed. Kim.
So for your very tired fellow who gathered that data, with 120 or so organs that were NAT negative, serology positive,
Mhm.
do we know if those organs go to the immune?
So we don't. So we have finally gotten approval from UNOS to link the Opio data to the UNOS records. We will very soon know a lot more. So we'll know whether they were classified as increased risk or not. We'll know whether the organs were utilized.
It'd be nice to know if they weren't utilized, why? Because the whole argument there is that we're going to have all these extra organs to use.
Yeah.
You know, my feeling is this, many of those organs may be being used right now.
Yeah. What I can say, though, is that we know from Doris Segev's data that for Hep C antibody positive organs, the utilization rate is very heterogeneous from center to center, with some centers taking very few of those organs, others taking all of them. And really, hopefully, what this would do is take someone out of that group and move them into the essentially Hep C negative range, where you get a higher or more close to 100% utilization. But our goal is definitely to look at the utilization. And actually, what her next project is that she's working on now is she's got from 32 of the OPOs, all of their NAT data, and since we have approval, we're going to try to mesh that together with the UNOS data to look at utilization. The thing I worry about, and I'd love any thoughts about this, is when organs aren't utilized, I don't trust the codes that we put into the UNOS database about why we didn't accept them. So we're going to look at that, but I just don't think it's going to. But yeah, I mean, we're going to look at that, but I'm not sure if that's going to capture it all in some regards.
Has the increase of disease transmission decreased since we have utilized NAT test? Because it's clearly the best test, but should we be talking about sensitivity and specificity of the test, or are we just fortunate that the biology of disease transmission is just poor? Even if we miss it, most of the patients don't get it anyway.
Yeah. So I think that the challenge is that we've spent all our effort looking at HIV, Hep B, and Hep C, and yet the actual number of transmissions related to HIV, Hep B, and Hep C are relatively small. So if you look at things that we transmit a lot, it's probably bacteria, followed by fungi, would be my guess if I had to prioritize. And yet, if you look at the number of publications for bacterial transmissions, for example, there's probably somewhere in the neighborhood of 30 or 40. And yet, for HIV, Hep B, and Hep C, if you add, especially if you add all the opinion pieces and things like that that have been out there, there's hundreds. And so I think the challenge is that I don't think with this NAT testing that we're going to see a huge change in the decrease in the number of disease transmissions. Where I think that it's useful is when the patient asks you, did you do everything to prevent this from happening? You can safely say yes for HIV, Hep B, and Hep C. I think that we don't have enough data yet to know how best to minimize the risk of bacterial transmission. And one of the best example that I give, so all the ID people know that we screen people in the ICUs for these resistant bacteria, yet that data is not collected in any way by OPOs. And I just asked to a DTAG meeting one time, should we be looking at this? And everyone just said, "Oy, that's going to be a lot of data. I'm not sure what we're going to do with it." So, I mean, I think that the challenge is that the proportion of patients that are infected with these resistant bacteria is only going up. We're going to be forced to deal with it at some point. We just haven't put the thought or resources into it yet.
So, currently, I'm sure you talked about CDC High Risk, because we have a 5 chance of dying on the liver list. So to find out that somebody who's very sick turned down a CDC high risk donor when they have, a 5 to 10% chance of dying and a negligible chance. So first of all, I wonder if it's a little bit of almost a disservice sometimes the way we approach patients. But my question to you is, if you take those 750 transmissions with 67 deaths, have you looked at what the breakdown is as a percentage? What percentage were CDC high risk versus non-CDC high risk?
So what I will say is that the classification is PHS increased risk donors, and this is my kind of soapbox time. I think part of the challenge is we keep saying high risk when in fact it's really not high risk. So we should be
Higher risk.
because, and we say, oh, it's fine. I don't really say that, but you accidentally say that to patients and they freak out. But it doesn't correlate well with disease transmission. But that being said, it was designed to screen for HIV, Hep B, and Hep C. And as I sort of mentioned, we don't see a lot of that. So I'm glad that it doesn't correlate.
And that
in some
testing
regards.
works.
Correct. I think the bigger question is sort of kind of, I think what you're getting at with this is, have we spent too much time focusing on HIV, Hep B, and Hep C? And as I said, I think we have. I think that we should probably be focused on a lot of things. I think we should be looking at kind of more of a holistic risk approach. I mean, the risk of disease transmission is far less through these kind of things than BK for kidney patients or CMV in routine transplantation. And actually the most disconcerting thing, we did a survey at our center of 162 pre-kidney patients. And it was done immediately as soon as they got done with their pre-transplant intake education and things like that. And we asked them a couple questions about, do you know what increased risk is? Which virus are you concerned with? They all knew what increased risk was. No one knew what CMV was. And they were far more afraid they were going to get HIV post-transplant than CMV. And so what that tells me is that we're not doing a good job of talking to patients about what they need to be worried about in the post-transplant period.
What does a much more integrated system like Spain do?
Yeah. Well, unfortunately, Spain's integrated system has had the plug pulled. So unfortunately, their Resistra, their Resistra cohort got pulled because they ran out of money, unfortunately. So I think what we need to do is what they did is, so their Resistra cohort for 2 years very carefully collected data on all of the patients, what the outcomes were. Where I think that the question to ask is Switzerland, and they're going to be the country to watch. Swiss Transplant has funded a 5-year project where they are looking at, part of it is they're lucky. They do something like 300 transplants a year. It's a very small system. But they're collecting every bit of information on the donor, on the recipient. They're going to get all that data about why donors weren't accepted, which I think is that's their first paper that they're going to produce. And I think that's going to be a real thought generator. They're going to look at every infection, and they're collecting everything that happens to them post-transplant. And they're going to try to go backwards and see, was it from the donor or not? So I think that's where a lot of the information can come. I think that the government should fund a similar project with a couple of OPOs or transplant centers to really get that information in the United States, because although we can learn a lot from Switzerland, it's a really different system than what we have in the United States. And although, as I found, there's a lot of drug use in Zurich, for example, it probably is not as bad as some cities in the United States. And definitely, things that they do may be very different from what we do, and so they may have different risk factors and outcomes. I think there was a question.
You have mentioned testing, one of the things that, you use to decide, the high-risk donor, how much that could help you maybe open up organs. Not even 3 years ago, we were discussing that there was not enough testing and the turnaround time was not good. Do you feel any different now?
Yeah, so based on our survey, and I didn't put up the turnaround time, but I gave you the surrogate of that. So over 75% of OPOs felt that they really had the information in real time and could give it before transplantation. The thing that is a little bit concerning is that the time from blood being collected to getting the result back is still averaging about 18 hours. So that's a long time to get some of the tests. Now there's a big, there's some places where it's 6 hours. There's some places it's 36 hours. So I mean, there's a range there. A lot of it has to do with transportation time because for parts of the country, for example, the whole Southwest, all the testing is done in LA, and so they use commercial planes to get the blood to the lab in LA, and so if you draw the blood at 3 a.m., it sits around until 6 a.m. to get on the first flight, and then gets there and gets stuck in traffic, and so quickly you add, and then you have a positive test, and you have to do confirmation, and then you're up at 10, 12 hours. So I think that there's ways that we could probably cut down on the time, and we were actually talking earlier, the group up in Seattle has been using their blood bank to test their blood, and they've actually been able to show very short time from blood draw through result. They've been able to use very high throughput systems with high reliability, a lot of automation to reduce the false positives. So I think we need to look very creatively at how we're doing some of this testing. I think we're getting better. We're not there yet.
So in the time of the season, and so forth, is there any recommendations such as, for example, breast transmission, or in high endemic areas? And so things change. For example, like babesia, and so it's already reported. And certain areas there is higher likelihood of certain chronic, other chronic illnesses that we need to worry about in transmission.
Yeah. So there's two questions I think embedded in there. First is what can we actually test for in real time? And so part of the challenge, like for babesia, is there isn't really a good test to screen in real time patients. So this is an issue for blood, and so we're probably going to get a test that's approved for blood that we may be able to use for organ patients as well. For West Nile virus, there was a consensus conference that was held, I think, 2 years ago that really suggested that if you do testing for West Nile virus, that it be restricted to when there's endemic disease. It was recommended the best way to find out about that is actually working with the blood banks because they have to do screening of blood products. When you start getting positives, that's when you should start doing NAT testing in your lab. And that more importantly, I'm less concerned at the front end, I'm more concerned at the tail end. When do you know how to stop? Because if you're doing West Nile NAT in January, almost all those positives are going to be false positives, and no one's going to want those organs. So, being very careful with that. And I think although there are challenges with the West Nile virus PCR and that you're going to get a couple of false positives, the risk of transmitted disease is relatively high with significant morbidity and mortality. And so in general for West Nile PCR positive donors, unless you can do some confirmatory tests to show that it's not true, you probably shouldn't use those. You shouldn't be using serology. It has cross-reaction issues. It stays positive forever, so you shouldn't be using serology.
One last question.
Sure.
Blended.
Uh-huh. Sure. So, yeah. So if you're getting a new positive serology, that's the easy one. New positive syphilis serology, that counts them as PHS increased risk because it's a STD within the last year. So that's actually the easier one. So that classifies them. And actually, we just had a living donor that had a chlamydia test that came up positive as part of her pre-donation PAP, and we classified her as increased risk. Now, getting back to the other question, it is hard. It's very hard talking about these issues with the donors, but we actually ask all the questions. And we've actually found that they're more than happy. Now, where it gets dodgy sometimes is the son who hasn't come out to their parents that they're donating and how to deal with that. And we work very carefully with them. And we've had that happen, but we've generally gotten the things to move forward. Because we were involved in the HIV Hep C transmission event, we are super draconian. You know, if they're identified as increased risk, we have to inform with the donor's consent the recipient that they're increased risk. They're of course going to ask our feeling, and we put this in a position paper that you should be telling them what the risk is, because if you don't tell them and they figure it out in the back end, then they're going to lose, we think they're going to lose trust in you. And you, again, you don't want to have the disclosure in an uncontrolled setting, in our view. So we try to facilitate that. If the donor doesn't want to disclose the information, we give them a medical out so that they can get out of the donation. With regard to testing, so what you have to do is you have to look specifically at your own center. We do HIV PCR testing every day, but we only do Hep C testing Monday and Thursday, and the blood has to be in the diagnostic lab by 9 a.m., which is really hard to make sure you get it there. So we've decided 14 days is our goal, and we try to get the patient to come in so that we can be sure that there's time to do the initial test and a confirmatory test before the transplant has to occur. We have been doing this for since the HIV Hep C transmission event in 2007. We've not had a single case canceled. We had one case delayed, but that was because the testing was initially positive and turned out to be truly positive, and the delay was to find another donor.
Well, thank you very much, Mike, and this was a terrific presentation. And well, I had not mentioned that Dr. Aizen is on the board of the American Society of Transplantation and also at the UNOS-OPTN, so he's in a perfect place to lend his expertise and help us with policy and practice update. Thank you so much.
Thank you.